my study was entitled Evidence of Cervical Cancer Downstaging in Tanzania. So a little bit of background information on cervical cancer. It is the second most common malignancy among women worldwide, and in the developing world, it's the most common malignancy. East Africa actually shares a significant portion of that burden with an estimated annual incidence of 40.1 per 100,000 population, which is the second highest worldwide, and it has the highest mortality rate worldwide with 30 per 100,000. And at the Seoul Comprehensive Cancer Institute in Tanzania, Ocean Road Cancer Institute, 40% of all cases diagnosed are cervical cancer. So screening and prevention of cervical cancer looks a little bit different in the developing world. So VIA and VILI, visual inspection with acetic acid and visual inspection with Lugol's iodine, have been used for decades as a cost-effective alternative to pap smears. So what happens is a trained nurse performs a vaginal exam and the cervix is washed with either acetic acid or Lugol's iodine, and those substances interact with the excess protein in precancerous cells caused by hyperploidy. So a visual white or yellow splotch, depending on the substance, can be seen, and that indicates precancerous lesions. And those are detected and subsequently treated in a screen-to-treat approach, which is same day. And ORCI uses cryotherapy, but you can also use thermocoagulation, cold knife conization, and LEAP. And since 2002, ORCI has been offering daily screening utilizing these methods, free of charge. So clinical downstaging is the utilization of these screening methods to detect disease at earlier stages and reduce the proportion of women presenting with late-stage cervical cancer. So in areas with such high prevalence of cervical cancer, it's not enough to just want to detect the precancerous cells and prevent them from developing into invasive cancer. You also want to have at-risk women come earlier and earlier, perhaps when they have asymptomatic stage 1 or stage 2 cervical cancer, where treatment is less complicated and their prognosis is much better. So given the sheer size of the screening program at ORCI, where about 3,000 women are screened each year, I was wondering whether downstaging was occurring within the population of women who were screened at ORCI over the 16-year period that it has been in progress. So the methods for this were a previous CEASE student named Andy Gard, who was part of the CEASE 2012 cohort, actually collected data on the stage of diagnosis of all women who were screened and then subsequently treated at ORCI from 2002 to 2011. And he also included a random sample of women who were treated but not screened at ORCI. So how he did this was he had the annual patient logbook of all women who were treated at ORCI for cervical cancer, and then he had an EpiInfo database which existed of all women who were screened at ORCI. And he used a SAS algorithm which he created to match these women, so he knew exactly which medical records he needed, and this was then verified by the presence of a blue screening card in their medical record. So my plan was to copy this protocol to a T because he was very successful. Unfortunately, when I got to ORCI, I found out that that EpiInfo database no longer exists. So we went at it a couple ways, and I talked to Solomon about it, and at one point when he was on site, we started calling it the Murphy's Law of Studies, because everything that possibly could have gone wrong did. But we finally figured out that in order to identify who was screened at ORCI of the women treated, we had to look at every single medical record of every single woman treated for cervical cancer at ORCI. Unfortunately, the year 2013 logbook was destroyed, so I could only review the years 2014 to 2018, and a total of 5,463 medical records were reviewed, and 505 of those patients were identified as having been screened at ORCI through the presence of the blue screening card in their medical record. And from those, information on stage, region, age, and biopsy were all abstracted for the records reviewed. So my final cohort was 6,631 patients. Of them, 1,250 were the women screened at ORCI and then subsequently treated, and 5,381 of them were those who were not screened at ORCI but were treated. If you remember, for the years 2002 to 2011, that was just a random sample of 333 women, and then the full patient list from 2014 to 2018. So my results. So in order to assess the presence of downstaging, we had to look at the proportion of women presenting with late-stage cervical cancer to the clinic, and that would be expected to decrease over time. Women who were not screened were used as a comparison. So if we are seeing a significant downstaging within the group of women screened, we use the women unscreened as a comparison group to see if this is just a nationwide trend we're seeing or if it's really due to the screening clinic. Patients were grouped into 5-year blocks, and a chi-square analysis was utilized to assess whether changes in the proportion of women presenting with late-stage cancer were statistically significant. And here we are, the stage of diagnosis of those presenting to the ORCI screening clinic with invasive cervical cancer from 2002 to 2018. And these are grouped into 5-year blocks. I ran the analysis separately with each individual year, and the graph looks a little bit like this, but the statistical significance are exactly the same. So I grouped them into 5-year blocks to make it a little bit more digestible, but it's still significant regardless. So as you can see here, 44.5% of women from the first 3 years of the screening clinic's existence had presented with late-stage cervical cancer. And here, the most recent, this 3-year block, from 2016 to 2018, 28.7% of women presented with late-stage cervical cancer. So a chi-square analysis gave us a p-value of 0.0024, which means that this was significant. So I have not run the comparison analysis of the women who weren't screened at ORCI, so I can't say just yet whether or not this is the result of the screening clinic and not just a nationwide trend, but it's very promising and exciting to get a p-value like that. So possibilities for future research for myself, not only am I interested in downsstaging, I'm interested in the geographic distribution of that downstaging. So is that downstaging occurring equitably across all the geographic areas of Tanzania, or is it just occurring in women in Dar es Salaam who have much easier access to screening and treatment at ORCI? So that's my next step, and possibly another manuscript. Possible future research for C students. Consideration of precancerous lesions in this greater picture of downstaging, and possible changes in the proportion of women presenting with CIN 1, 2, and 3. Like I said, thousands of women are screened every year, so that wasn't really plausible to include in my study, but it would be very interesting. Similar to how I'm interested in geographic variation, it would be interesting to look at whether or not this downstaging is occurring with women who are HIV positive. And also demographic or epidemiologic differences in women who present with late-stage or early-stage cervical cancer or CIN 1, 2, and 3 would be interesting. My learning experience. So I like to call it creative problem solving. And yeah, so getting to ORCI and realizing that the EpiInfo database you needed wasn't there, one of the logbooks was destroyed, was a very intense first research experience. But it worked out really well, and I had a lot of on-site mentorship. Dr. Solomon came and helped quite a bit, and then the other C students who were in Tanzania were also very helpful. And we ended up getting the study done, so that was great. And the overwhelming number of records to review was a lot, but I was really lucky that a QD medical student was also there for a month, and Fatima Shalan, her project involved all cervical cancer patients for the year 2016, so she kindly also collected staging data for me so I could focus on the years 14, 15, 17, and 18. Workplace cultural norms is always interesting, but I found everyone at ORCI really helpful and really excited at the prospect of research. And managing multiple databases, that was where I got a lot of experience, because at one point, my database was Microsoft Access, Fatima's was Excel, Andy Gard's was SAS, and at some point before this meeting, even though I got back on Saturday, I had to make that all coalesce into one database, which I could perform SAS analysis on. And on-site mentorship was also really important. Dr. Msami at ORCI was really helpful in all of the aspects of our study area, and she also pushed us outside of our objective of being there. And these two photos here actually are of informational sessions that we had with future doctors of Tanzania. These were young women who were going to be entering medical school in Tanzania, and we had couple informational sessions with them at ORCI about common malignancies in Tanzania and what prevention and screening look like for those malignancies. And then that right here is a great example of the kind of records that I was dealing with. What makes me laugh about this picture was about 2 days after it was taken, the entire bookshelf collapsed under the weight of all of those binders. And it no longer exists. None of those binders are labeled either. That was rough. So for my future career plans, I'm entering my second year of my PhD at the University of Buffalo, and beyond this study, I'm also collaborating on a study which is evaluating perinatal exposures and breast cancer risk in women in Puerto Rico. And I plan to do my dissertation research on special populations within the United States. My long-term goals include a possible postdoctoral fellowship at NCI. And ultimately, I hope to highlight the disparities which exist within our understanding of cancer epidemiology in this very diverse country of ours. So I want to say thank you to Dr. Solomon, Dr. Michaelek, Fatma, Zoe, and Darcy, who are my fellow CEUF students in Tanzania, who are constant sounding boards for my multiple crises of research, and my on-site mentorship of Dr. Msami and Dr. Moisalagi. Thanks. Any questions?
Well, I might as well start.
Hi, Dr. Michael.
Hi. Enjoyed your presentation. I'm sure everyone in this room has stories about lessons they learned. Research doesn't go according to Hoyle. And it's a good lesson to learn early in your career because it's one that you're going to be relearning every year. So perhaps you can speculate on the downstaging, the trend.
Speculate on the source?
What do you attribute it to?
I haven't run whether or not this is a countrywide analysis or a countrywide trend that I'm seeing. I haven't looked at the other patients, the unscreened patients, but GlobalCan numbers haven't showed a change in the incidence of
So
cervical
within
cancer.
your own population, are you getting a higher proportion of rescreenees each year? So you're getting individuals who may have been screened 3 years ago and they keep coming back, and so that your denominator has a larger proportion of women who were previously screened as negative.
Unfortunately, the screening programs within Tanzania all operate separately, and none of them have electronic linkage or
Right.
even
So
electronic
there's no way
records.
of counting for rescreening.
I do have the information on the total number of women screened in Tanzania every year from the Ministry of Health, and I'm going to include that in my analyses for my manuscript. But no, unfortunately, there's no way to keep track of how frequently women are being screened.
Very good. Well, thank you.
Yeah, that was a really wonderful presentation. Thank you so much. As you were doing it, I was thinking of all the stuff you learned. And another way of framing this could be as an improvement project too. You know, that if you were Rip Van Winkle and went to sleep and then woke up and went back to Tanzania, what stuff would you say they should do to make this work, make it easier for somebody doing research in that? And I bet you have all kinds of insights about that could develop some systems for them. And that might be another paper too, a quality improvement paper about what you think might make things easier to ascertain the data you want to ascertain and set up a system that really works and is more bulletproof than what you experience. So, thank you.
Hi, I was looking at the presentation and my question is, have you considered doing a trend analysis instead of a chi-square test?
Yes, I have. I've been talking with a biostatistician about what's the proper analysis to do for this. This is just preliminary because I just returned I finished data collection just Thursday. So I just returned to the US on Saturday. But I think once I have the bigger picture of the unscreened women put together, I think that would be the most appropriate because I need to see if the trend is similar between the two groups and not just, it doesn't tell us much if we just know that it's changing in some way.
I would like to answer part of Dr. Michaelek's question about screening. Tanzania has a very interesting, well-established outreach community program for cervical screening. And I think part of the continuous analysis of this is to link the screening rates at different clinics or regions with the ORCI cases. Lindsey has information about places of residence and where these patients come from. Could be done with her data or a future student to match the individual data from the individual clinics with the ORCI. I think we have Almi Sidani here, who was in Tanzania maybe 4 years ago, and she published a paper, 2 sites from Tanzania, and where patients come from, whether they come from the clinics and referrals from the clinics or come from the same regions directly to ORCI. There's a lot to be done here in this analysis, and that's why we say at least 2 papers out of this work.
Yeah, no problem.